the excellent yesterday with Professor Enrico. Today, we have also a wonderful day. Will be. I hope we succeed to have a good discussion with all of you. And please concentrate and even in the discussion on chatting. I have with me as a moderator Professor Mahmoud Hassanin, Professor of Cardiology, Alexander University, and two eminent speakers, our international speakers, Professor Enrico Rossi, the past president of the European Society of Hypertension, and Professor Costa Tisiofis from Greece, the past president, immediate past president of the European Society of Hypertension. The first presentation today for the hypertension with heart failure by Professor Enrico about hypertension, heart failure with reduced ejection fraction, and then we have a discussion. Enrico?
Thank you. Thank you very much. Good afternoon again, and it's nice to see you again. So, hypertension and heart failure. There is no doubt that hypertension, it's not going on. Okay, now it's work. Okay, thank you. It is well known that underlying hypertension is present in a large number of patients with heart failure. Here you see sort of prevalence as taken from different epidemiological studies, and they show how high is the prevalence in heart failure, both heart failure with preserved ejection fraction and reduced ejection fraction. This introduced this topic of heart failure that may be reduced or preserved ejection fraction. Professor Tisiofis will talk deeply into the heart failure with preserved ejection fraction. I want just to introduce the fact that these two forms of heart failure differed in ejection fraction, so in function of the left ventricle, and also on the structure of left ventricle, being left ventricular hypertrophy and fibrosis and concentric left ventricular hypertrophy more frequent in heart failure with preserved ejection fraction, while dilatation of the left ventricle with eccentric hypertrophy is more frequent with reduced ejection fraction. And also for the main causes, because certainly female gender, aging, and also hypertension may be more frequent with preserved ejection fraction, while ischemic heart disease, previous myocardial infarction, male gender may be more frequent with reduced ejection fraction. We don't know still whether there is a transition through heart failure with preserved ejection fraction to that of reduced ejection fraction. However, it is believed that an additional hit, an additional myocardial damage, usually ischemic, but maybe also toxic, maybe also of genetic origin, may lead from uncontrolled hypertension to left ventricular hypertrophy to eccentric hypertrophy and heart failure with reduced ejection fraction. You also know that recently the guideline of the European Society of Cardiology have indicated a third form of heart failure with so-called mid-range ejection fraction, which is a heart failure with ejection fraction between 40 and 49%. And this is a form of heart failure with possibly different characteristics, but in general, on average, this may be considered as a mild form of heart failure with reduced ejection fraction. In fact, treatment in heart failure with mid-range ejection fraction are the same as those for reduced ejection fraction, usually with a better outcome as for reduced ejection fraction, and contrary to what happens with preserved ejection fraction. These forms have usually similar morbidity and also mortality, although in some studies mortality may be higher in patients with reduced ejection fraction. Having said that, let's consider shortly the cardiac structure and functional alteration in hypertension that may lead to the development of heart failure. Certainly, the pressure overload, particularly the overload close to the heart, what we may more or less measure with the central blood pressure and pulse pressure. So the overload may induce a change, also a change in transcription genes for myocytes and extracellular matrix, leading to changes, cardiomyocyte hypertrophy, but also loss of changes and functional changes, and an increased collagen content that increase the stiffness of the heart. In addition, also the vascular compartment may be impaired in hypertension, with alteration in large arteries, particularly in epicardial arteries, in the microcirculation, and also in the form of capillary rarefaction. All these may lead to systolic and diastolic dysfunction, and therefore may permit the transition from asymptomatic to symptomatic congestive heart failure. Central to this chain of events is the development of left ventricular hypertrophy. It has been also calculated that the hazard for heart failure may increase by 1% for each 1% increase in excess of left ventricular mass. What is called, for instance, inappropriate left ventricular mass, when the mass is higher than what may be foreseen by the blood pressure load. And we have also demonstrated that if during treatment left ventricular mass remain inappropriate or become inappropriate, larger than what may be predicted, then the development of congestive heart failure is more frequent. Certainly, treatment of hypertension may prevent the development of heart failure. This meta-analysis by Alberto Zanchetti and co-workers demonstrated that for any 10 millimeters of mercury of reduction of blood pressure in 4 or 5 years may reduce several cardiovascular events, and particularly heart failure, with a reduction which resulted greater than 40%. And this is particularly evident in the early. You can see the result of the HIVAT study that demonstrated that for this reduction in blood pressure, there was a decrease of more than 60% of the incidence of heart failure. Looking at the effect of the different classes of blood pressure lowering drugs, these meta-analyses that included very large number of patients, more than 600,000 patients, demonstrated that while ACE inhibitors, angiotensin receptor blocker, and beta blocker had all the same effect in terms of prevention of heart failure, calcium channel blockers were apparently inferior to the other classes of antihypertensive drugs, while diuretics have some advantages, particularly symptomatic advantages. So calcium channel blockers are believed to be less effective in reducing the incidence of heart failure. However, a more recent meta-analysis by Zanchetti and collaborators demonstrated that this inferiority of calcium channel blockers disappeared when the meta-analysis included only randomized clinical trial that allowed the concomitant use of diuretics, beta blockers, and renin-angiotensin system blockers, thus demonstrating that they are not dangerous per se. They do not reduce the efficacy of the other drugs, but are very effective in reducing blood pressure. So let's look at treatment of heart failure with reduced ejection fraction and its relation in some way with blood pressure. And I want to start with what is indicated by the recent European hypertension guidelines. Certainly, blood pressure should be lowered with patients with heart failure as blood pressure above 140/90. This is not frequent in those with reduced ejection fraction, but it may happen. It is apparently more frequent in those with preserved ejection fraction. And the drugs to be used are those that have been proved to be effective in improving the prognosis in heart failure, thus the renin-angiotensin system blockers, the beta blockers, and diuretic, plus mineralocorticoid receptor antagonist if required. But also calcium channel blockers, in particular dihydropyridine calcium channel blockers, may be added if blood pressure control is not achieved. It is recommended also to treat early left ventricular hypertrophy, and in this context, certainly angiotensin receptor blockers, ACE inhibitors, and calcium channel blockers may be more effective than other drugs with a reduction of blood pressure between 120 and 130. Blood pressure in patients with heart failure may have an important prognostic significance. Usually, low blood pressure is associated to a worse prognosis. But interestingly, during treatment, blood pressure may be even increase if treatment is effective. And in fact, at least in this study, in study of valsartan in heart failure, any 1 millimeter increase in systolic blood pressure from baseline to 4 months was associated with a significant decrease in the risk of hospitalization for heart failure. And the same can be seen as a consequence of effective cardiac resynchronization treatment that, when effective, was resulted associated to an increase in systolic blood pressure. So there is this reverse effect, because improving the pump function in patients with heart failure, reduced ejection fraction, blood pressure may even increase, although slightly. If we are going back to the European guidelines, which is the therapeutic algorithm for these patients with ejection fraction below 40% or below 35%, the initial treatment is with diuretics that are helpful in reducing congestion, and with an ACE inhibitor and the beta blockers that have been demonstrated effective in improving prognosis. An angiotensin receptor blocker should be used if ACE inhibitor is not tolerated. If this is not enough, the patient remains symptomatic, mineralocorticoid antagonist can be reduced. If still symptomatic, then we can replace the ACE inhibitor with angiotensin receptor neprilysin inhibitors, an ARNI drug, or if there is a duration QRS with still a consistent reduction ejection fraction, we may consider cardiac resynchronization. If the sinus rhythm is above 70 beats per minute, ivabradine may be indicated. If symptoms are persistent, other possible treatment may be considered, but certainly this is a severe form of the disease. And this algorithm leads to a more recent trial that have considered relatively new drugs. First of all, the use of angiotensin-neprilysin inhibitor in heart failure in these patients as compared to enalapril. The rationale for this treatment is that the inhibition of neprilysin may permit the increase in the concentration of some endogenous vasoactive peptides, including natriuretic peptides, that may have a favorable effect on neurohormonal activation, on vascular tone, on cardiac fibrosis, on sodium retention. All of these are reduced. I hope you can see my slides, because there is some overlapping of lines for what I can see from my computer. Okay, going on. You know very well that these angiotensin neprilysin inhibitors was able, in this large group of patients of reducing the primary endpoints of death, cardiovascular death and heart failure hospitalization more effectively than the ACE inhibitor enalapril, with a reduction of 20%. And this was true also for the single endpoints considered separately: cardiovascular death, all-cause death, and hospitalization. And this was the first approach that further reduced the efficacy of this neurohormonal treatment in patients with heart failure and reduced ejection fraction. And very recently, in network meta-analysis, it was observed that the combination of angiotensin-neprilysin inhibitors plus beta blockers plus mineralocorticoid receptor antagonists was most effective in the combination of drugs in patients with heart failure and reduced ejection fraction. Now, even more recently, a few months ago, I have to say, a new approach has been considered, and this was performed with a drug that has been used in patients with type 2 diabetes, and an inhibitor of SGLT2 receptors that were already tested in patients with diabetes and high cardiovascular risk, and have been found able of preventing all cause mortality, but also heart failure. And this drug, dapagliflozin, in this important trial, was tested in patients with established heart failure and reduced ejection fraction, with or without diabetes. And dapagliflozin was given to this group of more than 4,700 patients with heart failure, ejection fraction below 40%, those 10 milligrams in comparison with placebo, in addition to the other treatment. And the conclusion of the study was among these patients, the risk of worsening heart failure or death from cardiovascular causes was lower among those who received dapagliflozin than among those who received placebo, regardless of the presence or absence of diabetes. So even patients with heart failure, reduced ejection fraction without diabetes, this drug may be effective. And these are the figures. All the outcomes, not only the cumulative incidence of primary outcome, but also separately hospitalization for heart failure, death from cardiovascular causes, death from any cause, was significantly reduced by this drug. These drugs that apparently is acting over and above neurohormonal blockade with RAS blockers or angiotensin neprilysin inhibitors, acting perhaps above the natriuretic glycosuric effect, having an effect perhaps on cardiac function, cardiac metabolism, having an effect on the large vessel and also in the kidney, reducing glomerular pressure and albuminuria. So the consequence of these very interesting effects is a reduction of all the cardiovascular endpoints. Okay, we have further treatments. I'm not going into details for this, but was just to remind that for the treatment of heart failure with reduced ejection fraction, also potassium-lowering agents may be useful. We have observational data indicating that too low, too high potassium is very dangerous, and particularly using drugs that blocks the renin-angiotensin-aldosterone system, potassium may rise. So these potassium binders may be quite useful. Also, the treatment of iron deficiency with ferric carboxyl maltose has been found effective so far in a meta-analysis in reducing hospitalization for heart failure, not yet for reducing cardiovascular events. And in addition, we may have devices, and for this form of heart failure, we may consider cardiac resynchronization treatment that is useful in patients with enlargement of QRS and reduction of ejection fraction. In patients with implantable, may use implantable cardiac defibrillators, particularly in younger patients, may prevent sudden death. We may use telemedicine. Percutaneous mitral regurgitation treatment may also be useful, and also mechanical cardiac support at the very end of the story. I don't want to go into details, as I said, but these are possible approaches. To conclude, we may say that despite all these significant advances in therapy for heart failure with reducing ejection fraction, the estimated 4-year survival for patients with symptomatic heart failure is only 60%. So new therapies must be pursued in order to fully repair the abnormalities in cardiac structure and function that are the cause. And the most effective method of treating hypertensive heart failure is primary prevention before the onset of pathologic remodeling and overt heart failure. So appropriate and early antihypertensive treatment. Thank you very much for your attention.
Thank you, Enrico. I think it's wonderful illustrations of hypertension. I will start with one question, then I leave Dr. Mahmoud to lead the questions. You know, as he is starting the hypertension, there is an aortic stiffness and increased central aortic pressure. Do you think that we need to measure the stiffness in such patients to prevent the heart failure, preserve ejection fraction, and finally heart failure with reduced ejection fraction?
Well, if possible, certainly decrease in arterial stiffness and particularly central blood pressure should be a desirable goal in these patients. Let me say that reducing blood pressure per se is reducing the aortic stiffness. So the main goal is to reduce effectively blood pressure with the target blood pressure that are advised by guidelines. Then, of course, if you measure or try to measure with, we may say, not perfect methods, but useful, clinically useful methods, if you want to measure aortic stiffness, central blood pressure, these perhaps may be useful in the follow-up of the patients. But the most important thing is, of course, to reduce the global pressure load to the heart.
Mahmoud.
Okay, Professor Enrico, thank you for this very elegant talk. You know, the prevalence of hypertension in our Egyptian heart failure registry was only 45%, which is much lower than the prevalence in Europe. This was the prevalence in overall heart failure, whether reduced or preserved ejection fraction. My question is, hypertension is a major contributing factor for heart failure, but once the patient has heart failure with reduced ejection fraction, I don't think that high blood pressure is a major issue in the management of these patients. What do you think?
Yes, I agree with your comment. When we consider the importance, the prevalence of hypertension in heart failure, we consider mainly underlying hypertension. I mean, a story of hypertension, treatment for hypertension that initiated before the development of heart failure. I agree with you that with the reduction of systolic performance of systolic pump, then blood pressure may be reduced. And when we see patients with heart failure in advanced stage, it is more difficult to observe an increase in blood pressure, but the history of blood pressure is still there. And it is interesting that if you improve pump function in these patients, even using drugs that usually reduce blood pressure, diuretics, ACE inhibitors, beta blockers, in this case, improving the pump function, blood pressure may rise a bit, as I've shown. And this may be a good indicator that the pump function can be recovered through pharmacological treatment.
I have another question. You know that hypertension just is a risk factor for heart failure, and according to the ACC-AHA classification, is stage A. And if you have a hypertensive patient with left ventricular hypertrophy and diastolic dysfunction, this is stage B. Can we prevent progression from stage B to stage C, which is clinical heart failure, by serial follow-up of BNP? Do you have record any experience with this? Trial of observing transition from stage B to stage C by serial follow-up of BNP?
Yes, well, certainly with appropriate antihypertensive treatment, left ventricular hypertrophy may be reduced, left ventricular mass may be reduced and may return within normal range. Diastolic function may also be improved, but this may happen only if you start quite early in treatment, because as possibly I'll try to show later, if you start a bit late treatment, then the reversibility of this alteration is only partial. So I think that it is possible to prevent this transition from B to C, but this is possible only if you treat quite early these patients in order to get a true regression.
Yeah, I have a question from the audience. Why is cardiac hypertrophy in athletes is not considered a problem while it is so in hypertensive patients?
Sorry, I have not catch the
question from the audience. Why is cardiac hypertrophy in athletes is not considered a problem while it is a big problem in hypertensive patients?
No, I think we should consider it as a problem. We have been involved in the study of this topic for many years, and I am convinced that this is a big problem. But as I said, the problem is that perhaps the diagnosis is made a bit late, particularly in the past when the diagnosis was made preferably using electrocardiographic techniques that are not so sensitive to detect initial alteration. So once left ventricular hypertrophy may be diagnosed with the electrocardiogram, this is in an advanced stage. And at this stage, it is more difficult to prevent the evolution towards heart failure. I repeated, we have to start earlier the treatment in these patients if we want a useful regression of the damage. But I think it's very important, left ventricular hypertrophy.
Yes, okay. Dr. Sobhi?
Few questions coming from the audience. Dr. Hadi Abu Hantas from Jordan. What's your vision in improving survival rate at 40 years in heart failure with reduced ejection fraction? Are we starting in our treatment too late?
Oh, again, I think that in medicine, we have to start treatment as earlier as possible if we want to get good results. Certainly, we need new drugs. It is obvious that not in every patient it is possible to start quite early for several reasons. We observe patients in an advanced phase, and of course we must take care of these patients, and so far we have the availability of drugs which are effective but not so effective as we wish they should be. So new drugs are welcome. So we have to approach the preventive approach, primary preventive approach with an early treatment, and then another approach with new treatment in order to improve the survival. Survival for patients with advanced heart failure is very poor. It's like people with cancer, perhaps worse than those with cancer. And this indicates that we have to start early. But when we see these patients, we have to use all what we may in order to improve their treatment, their management.
Thank you, Enrico. Mahmoud, can you introduce that?
Yes, well, with the second. Okay. Let me introduce you. Professor Konstantinos Tsoufis from Greece. His talk will be about hypertension and heart failure with preserved ejection fraction. Where do we stand? Professor Tsoufis.
Good afternoon. It's a great pleasure to me to be with you in this very interesting session. Thank you so much for the invitation. The excellent talk delivered by Professor Agapiti Rosei makes my job much easier. I will start with some data regarding the epidemiology between hypertension and HF-PEF. Then I will discuss very briefly the pathophysiology, and in the third part, I will present some data regarding the therapeutic management of heart failure with preserved ejection fraction. There is no doubtful that heart failure with preserved ejection fraction will soon become the dominant form of heart failure in many parts of the world. Data from the optimized HF registry show that 30 to 50% of all heart failure admissions are with preserved ejection fraction. On the other hand, the prevalence of hypertension in patients hospitalized for HF-PEF was higher compared to the prevalence of hypertension in patients hospitalized with HF-REF. Don't forget that blood pressure control is important for primary and secondary prevention of heart failure. There is no difference in the clinical presentation of these two types of heart failure. There are similar signs and symptoms in patients with HF-PEF compared to patients HF-RF. Edema, orthopnea, rest dyspnea are the most common symptoms. And as Enrico previously correctly mentioned, HF-PEF is more common among females, among elderly people, and among obese patients. The prevalence of hypertension is higher in patients with HF-PEF compared to HF-RF. But the problem with heart failure with preserved ejection fraction is the large heterogeneity. There is one syndrome, but with multiple causes and multiple phenotypes. Apart from the high prevalence of HF-PEF among elderly, among patients with COPD, among patients with chronic renal failure, diabetic patients, obesity, and as well as in patients with obstructive sleep apnea. But also HF-PEF is common among patients with previous cancer therapy, post-MI, although post-MI HF-RF is more common. And we see nowadays in the era of TAVI, a lot of many cases with heart failure with preserved ejection fraction, even after aortic valve replacement for severe aortic stenosis. Also, cardiac amyloidosis and the reverse remodeling HF-RF may have a phenotype similar to the previous case. Coming to the diagnostic approach, we recognize that the classification of heart failure is based on the ejection fraction. And nowadays, ejection fraction has become the most important single number in cardiology. But actually, ejection fraction tells only a part of the story. Apart from the preserved ejection fraction, higher than 50%, we need in a patient with HF-PEF at least some structural and functional alterations. Increase in left ventricular volume index or in left ventricular mass index, functional alterations indicating diastolic dysfunction, increase in NT-proBNP over 125 picogram per ml, or in BNP higher than 35. In these slides, we appreciated some echocardiographic findings for patients with HF-PEF. We appreciate here the increase in left ventricular volume index, associated with the predominant passive transmitral flow and the reduced tissue velocity in the median and the lateral wall. Also, the patient is accompanied by pulmonary hypertension, while the regional and the global longitudinal strain is within the normal values. In any case, with HF-PEF, we have to exclude some other conditions that may present with the similar signs and symptoms. For example, restrictive cardiomyopathy, hypertrophic cardiomyopathy, pericardial disease, storage disease, or right ventricular failure, in order to be sure that these symptoms are related to the diagnosis of HF-PEF. Coming to the pathophysiology, as previously Professor Agapiti mentioned, there are different pathways from hypertension and left ventricular hypertrophy to the development of heart failure with preserved or reduced ejection fraction. The majority of patients with asymptomatic left ventricular hypertrophy will develop HF-PEF, about 70% of the patients, and the remaining 30% will develop left ventricular heart failure with a mid-range ejection fraction or with reduced ejection fraction. We discussed previously the important role of arterial stiffening in the development of heart failure. And this is particularly true in the case of HFpEF, where there is the increased velocity of the incident wave results in the early return of the reflective waves with the increase in systolic blood pressure, decrease in diastolic blood pressure that results in the increase in left ventricular afterload and decrease in the coronary perfusion, resulting in the reduced coronary flow reserve and the perfusion mismatching. We have previously shown an inverse relationship between aortic stiffness and diastolic dysfunction, and also the important role of subclinical inflammation, as represented here by serum amyloid A, or also with high sensitivity CRP, with the left ventricular adaptations in the case of uncontrolled hypertension. In the same lines, it is important to highlight the important role of the coronary microvascular endothelial dysfunction. This results in the increased oxidative stress and the promotion of inflammation. At the levels of cardiomyocytes, there are quantitative and qualitative changes through alterations in the phosphorylation of titin sites. But also at the level of fibroblast, there are similar changes with increased degree of fibrillar collagen cross-linking. This combination of changes at the level of cardiomyocytes and the level of fibroblasts would lead to the increase of myocardial passive stiffness. Last but not least, I would like to stress out the importance also of the epicardial fat accumulation and the accompanied inflammation in the pathogenesis of left ventricular hypertrophy and the pathogenesis of HFpEF. As we see here, the epicardial fat accumulation could lead to the accelerated coronary atherosclerosis, to atrial dysfunction and to arrhythmias, particularly to the atrial fibrillation, but also to heart failure with preserved ejection fraction development. In summary, apart from this traditional model, where the increased hemodynamic load and the associated vascular dysfunction will lead to all these structural functional adaptations in order to develop heart failure with preserved ejection fraction. Also, there is an emerging modeling where there is some clinical inflammation also has a dominant role. In the end, this mechanism may act as complementary in order to increase the left ventricular and diastolic pressure at rest and exercise with the development of heart failure signs and symptoms. Let's move now to the therapeutic considerations. Unfortunately, the last guidelines provide the same statement. No treatment has yet been shown to reduce morbidity and mortality in patients with heart failure with preserved ejection fraction. Accordingly, in the current treatment of HFpEF, include to consider alternative diagnosis, to treat symptomatic with status with diuretic, to treat hypertension, and also to achieve a rate control in atrial fibrillation and to treat ischemia. Not doubtful about the important role of high blood pressure and the opposite, the controlling blood pressure to reduce heart failure. Data from the HIVET study, but as well as data from the SPRIT trial showed very clear the important role of reducing the blood pressure according to the guideline targets. In these lines, we have shown that also the time in therapeutic rates may contribute to the better cardiovascular outcome. Mortality rates in patients with established hypertension over the therapeutic or under or over the therapeutic range 120, 140 was associated with adverse outcome. There are a long list of trials in patients with heart failure with preserved ejection fraction, but unfortunately, all of them were at least neutral. Started from the chart-preserved trial, catesarstant compared placebo was not effective. The same irbesartan, the A-preserved, in the PEP-CHF study, perindopril was also neutral, and in the TopCat study, spironolactone versus placebo also was ineffective. But I would like to comment a little bit more on this important study in TopCat, where 3,400 participants randomized to spironolactone versus placebo. And the ejection fraction was higher than 45, or in the patients, the diagnosis of heart failure was based on the history of heart failure or based on elevated BNP. The primary endpoint, there is no difference between spironolactone and placebo, but there was a reduction, a statistically significant reduction in the heart failure hospitalization in the arm of spironolactone, and patients that were enrolled based on the high BNP had a significant benefit with spironolactone. Also, in this study, there was a geographical variation. In 2/3 of the patients in the United States enrolled with BNP and had benefit, while the 1/3 of the patients were enrolled in the Russia and Georgia based on HF, on the history of heart failure, and there is no benefit. That means that there are some methodological problems in this study, and maybe for this reason, the USA guidelines recommend use of aldosterone receptor antagonists for consideration in appropriately selected patients to reduce hospitalization in patients with HFpEF class 2B, particularly if these patients have elevated BNP or GFR over 30 for safety reasons. Let's go on with the other trials in HFpEF. No support for sildenafil, no benefit from nitrates, and also no benefits from ivabradine according to the NDFI registry. But as Enrico previously mentioned, we have some promising, very promising findings from the new drugs, empagliflozin and the other drugs in patients with diabetes mellitus. EMPA-RENC provide very, very promising data in patients with diabetes mellitus regarding the cardiovascular morbidity and mortality, and recently the DAPA-HF in patients with heart failure, independent with or without diabetes mellitus. Dapagliflozin resulted in a significant reduction by 26% in the relative risk of cardiovascular death or heart failure or an urgent heart failure visit. Of course, we expect to see the better reduced and the better preserved heart failure outcome trials to see if this new category of anti-diabetic drugs may provide some help in the management of patients with heart failure with preserved ejection fraction, since these drugs seems to have a pleiotropic spectrum, a spectrum of pleiotropic actions. We looking forward to see these results. And last year, we have the presentation in the European Society of Cardiology meeting of the Paragon-HF study with angiotensin and neprilysin inhibition in heart failure with preserved ejection fraction. In this study, 4,800 patients with HFpEF were randomized to sacubitril valsartan versus valsartan, with a primary endpoint, the composite of first and recurrent hospitalization and cardiovascular death. The primary endpoint was neutral, no significant benefit in the arm of sacubitril compared to valsartan. But also there were some interesting findings in pre-specified subgroups. In females and also in those with a median ejection fraction below 57, there was a significant improvement in the risk for hospitalization. So Paragon-HF was the first HF-PEF trial with a strong trend to benefit, without, of course, statistically significant difference, but these findings in the women and in those with, let's say, lower injection fraction below 70, below 57 or 50, we have to determine it, may provide some interesting, some hopes for some improvement. So, going to the end of my presentation, as a practical guide to symptomatic patients with HF-PEF, I would suggest diuretics for edema or for hypertension, idapamide if elderly, according to Hyvet, or thiazide if younger, spironolactone, particularly in these subgroups, ACE inhibitors for hypertension, irrespective of age, RBS acceptable if intolerant to ACE inhibitor, beta blocker and particularly nebivolol, thanks to the senior study, epagliflozin, and resto in women and those with mid-range ejection fraction. And of course, we have to avoid rate controlling medication and exaggerate heart rate, blood pressure response. Potentially, we will have some help from anti-inflammatory therapies. We need more studies in this case, and also from device, particularly from renal denervation. We expect some help in the better management of patients with hypertension and heart failure with preserved ejection fraction. So, as a take-home message, I would say that HF-PEF is not one disease. So there is no one cure, no one treatment. The approach which worked for heart failure with reduced ejection fraction has failed multiple in heart failure PEF trials. More specific phenotypes describe disease-specific approach we need. The successful drug may be pleiotropic, but particularly take into consideration the close association of hypertension and HF-PEF. I think that in the treatment of patients with HF-PEF, it is important to have three main targets. To identify patients in risk of developing HF-PEF, to treat hypertension aggressively and earlier, as Enrico discussed previously, to prevent progression to HF-PEF, and to treat hypertension to relieve symptoms and reduce HF hospitalization. As all of you are aware, the 2020 ESH meeting was postponed to the, and please save in your agenda the new date, April 9 to 12, 2021 in Glasgow, and also please save in your agenda the date of the 32 European meeting, 2022 in Athens. Thank you so much for your attention.
Thank you, Professor Kostas, for this excellent presentation. I have one question. Do you think that treatment of high blood pressure in patients with heart failure and preserved ejection fraction is crucial? And what is the target blood pressure you would like to achieve in such patients?
We always, according to the guidelines, we target below 140, below 90. This is the general target. But if someone is younger than 65 years old, we have to target below 130, but avoid to go below 120 for systolic, and to target in the target range 80 to 70, irrespective of the age.
In the diagnosis, sorry, Mahmoud.
Go on.
Regarding the diagnosis of diastolic heart failure or preserved ejection fraction or the mid-range, as you said, in the Paragon, depending on the number, it could be effective in 45, 55. But in one of your slides, that ejection fraction is not the issue. You should have another speckle crackling, or have a tissue Doppler and something like that. So it's not measured in the Paragon. So what? So if I'm a doctor, I'm doing all the echo diagnosis, or depending again on the number of ejection fraction in order to start the neprilysin inhibitors. What do you think?
I cannot agree more with you. all these years, the classification and diagnosis of the different types of heart failure was based on the ejection fraction, but we all know the limitations of the ejection fraction. Of course, we need more sophisticated echocardiographic techniques to accurate estimate the systolic and the systolic function, as well as to estimate the diastolic dysfunction. But what I can say that at least I don't think that Paragon was completely neutral study. This is the difference compared to all the previous one. At least in females, and also we have to look and to find what is the appropriate ejection fraction. Maybe we can find some patients that may benefit from Entresto. Of course, if we take the main message, there is no any benefit. But maybe in some groups, if you have a symptomatic, practically speaking, if you have a patient with HFpEF, hypertensive patients, and remain symptomatic, despite the, let's say, the appropriate management according to the available drugs, and despite the achievement of controlling high blood pressure, if the patients remain symptomatic, particularly if this is a female subject, I think that maybe sacubitril provide some help in this patient.
Okay.
Question from the audience, then Dr. also Hadi Abu Hansha again from heart failure preserved ejection fraction patient do respond to guided medical treatment for heart failure. When the ejection fraction goes to less than 40, what are we missing there?
The last part, what?
What are we missing there? I mean, it's responding to guided. So what's missing now?
Yeah, this question related to your previous comment about ejection fraction, about the correct diagnosis of heart failure. Maybe this is the reason why all these trials have failed, because we approach heart failure with preserved ejection fraction with our approach is wrong. This is that we have to again to look for and to see that maybe we have to approach this problem in a different way. Unfortunately, I cannot provide a clear answer to this question.
Another question from the audience: is the hypertensive heart failure preserved ejection fraction carry special characteristics when compared with other forms of heart failure with preserved ejection fraction? The hypertensive patient.
Yeah, very nice question. What we know first, that the prevalence of hypertension is very, very common among patients with HFpEF. More than 80% of these patients with HFpEF are hypertensive. And also, the second, hypertension is associated with a cluster of other cardiometabolic disorders, with diabetes mellitus, obesity, sleep apnea syndrome. So it's very difficult to, let's say, to distinguish what is the contribution of hypertension per se and what are the contribution of the other comorbidities. For this reason, I think that this is HFpEF is one syndrome, but with different phenotypes, and maybe we need a different approach to correctly diagnose and to correctly manage these patients.
Okay. If I am in the practical guide, you put in the last slide practical guides. If I'm 75 to 80, mild edema with ejection fraction 50 or 45, so you advise beta blocker with diuretics, or you advise according to trials. I mean, you take one by trials. We have senior trials and we have TopCat trial. So do you think this TopCat patient or senior patient adding to diuretics, how can you manage this?
Yeah, of course, I would try first to achieve blood pressure control. This would be the first priority. And towards this end, for the edema, and once he is symptomatic, some diuretic maybe also it's appropriate. But also, senior provides signal for the favorable effect of nebucolol, and if the patient continued to be symptomatic and the kidney function was normal, or at least GFR over 30, I would also add spironolactone.
Mahmoud, do you have any question? Because you have to finish, I think.
No, we have no further questions.
Okay. You can close, Mahmoud. Okay.
Okay. I would like to thank Professor Costa Tsufis and Professor Enrico Agavati-Rosé for their excellent presentations. Professor Muhammad Sobhi, my co-chairman, and we have to close this session. Thank you.
We can have break just 10 minutes and then come back to him, okay?
Okay.
Thank you.
Bye-bye.
Thank you.
Okay, we are ready.
Okay.
Mohammed,
Okay.
you can start.
Start. Okay. Let's come back now after refreshment of 10 minutes. I think it's we have to have a break in between in order to refresh our legs, only to 5 to 10 minutes. It's an honor for me again to have another session about the management of hypertension. Finished the hypertension with heart failure, but now is managed hypertension, and two important topics. The first by Enrico Rossi, but optimize antihypertensive treatment, lower blood pressure, or earlier treatment. Enrico?
Okay, thank you. Well, you know very well this slide, which describe the direct relation between usual systolic blood pressure and stroke or ischemic heart disease mortality. There is this direct relationship going down up to below 120 millimeters of mercury, about 110, 115 millimeters of mercury, up to high values above 180. And this is true for several decades of age. So there is this direct relationship. But when we reduce blood pressure, we don't know exactly whether there is a return back to a reduction of the risk, which is similar to that in the positive relationship. In other words, when we reduce blood pressure, we obtain a result that is related to an impairment of several mechanisms that regulate blood pressure. There is a reset of some regulatory mechanism, but there is also organ damage, vascular structure alteration that when is advanced cannot be easily reversed. There is a neurohumoral activation, a reduction in renal function, the baroreceptor dysfunction. So we cannot be confident that there is in fact a regression of the risk in the line that indicate the relation between blood pressure and cardiovascular risk at baseline. So in my presentation, I'd like to touch shortly these 4 points. First, the issue of target blood pressure according to guidelines, clinical trials, meta-analysis. The issue of the J-curve. At low blood pressure, the risk may increase. The benefit versus harm from treatment. And finally, the residual risk and need of early treatment. Target blood pressure. This is the target of blood pressure according to the recent European guidelines in patients with hypertension and hypertension with associated disease or with complication at several range of age. For those below 65 years, as you know, the target of systolic is 130 or lower if tolerated, but not below 120. This is true for all these subgroups, except for chronic kidney disease, in which the target is between 140 and 130. For those with an age above 65 years, the target is between 140 and 130 if tolerated, particularly for those with an age above 80 years. While for diastolic blood pressure, the target is below 80 up to 70 and not below. These are the indication of guidelines that, of course, come from several randomized clinical trials that recently have been collected in several important meta-analyses. This is a very well-known meta-analysis by Etihad in more than 600,000 patients enrolled in 123 randomized clinical trials. And of course, for 10 millimeters mercury reduction, systolic blood pressure for 4 or 5 years, there is a clear reduction in all cardiovascular events, except perhaps in renal failure that probably takes more time to show an advantage, an improvement with treatment, and also all-cause mortality. And this relative risk reduction is similar irrespective of baseline blood pressure and also irrespective of baseline cardiovascular disease risk. The relative risk reduction is the same. But when we go lower to blood pressure, as in this meta-analysis by Zanchetti and co-workers, in which, interestingly, the patients were subdivided in 3 strata with the mean systolic blood pressure achieved by treatment versus mean systolic blood pressure achieved or in the placebo or less intense treatment. You can see by 10 millimeters of mercury, there was a direct comparison between between lower and higher blood pressure. And you can see that also going below 130 millimeters of mercury, there is still an advantage. Although in absolute terms, the risk reduction is lower, but there is a significant reduction of risk. Well, the conclusion was that in this updated meta-analysis, more versus less intense blood pressure lowering can reduce not only stroke and coronary events, but also cardiovascular mortality. You see, cardiovascular mortality significantly reduced. And including data from a recent randomized clinical trials, also the SPRINT trial is included. All measured outcomes can be reduced by lowering systolic blood pressure below 130 millimeters of mercury, but the absolute risk reduction becomes smaller. The absolute risk reduction, this one, is smaller, is lower. And this suggests that patients at lower initial systolic blood pressure were at a lower level of cardiovascular risk. So there is a reduction, but this reduction is small. Let's go now to the issue of J-curve, for which topic we have only observational studies. One most important is the so-called Clarify registry that included more than 22,000 patients with stable coronary artery disease. They were all treated for hypertension. Systolic and diastolic blood pressure for each event were categorized into 10 millimeters mercury increments, and the primary outcome was a composite cardiovascular death, myocardial infarction, or stroke. And this is the relation between achieved blood pressure and risk for this primary outcome. You can see that below 130, perhaps lower 130, and below 75 millimeters mercury diastolic, there was an increase in risk. And this was known also from previous post-hoc analysis of randomized clinical trials, such as the INVEST. You can see that considering, for instance, diastolic blood pressure, which is particularly important in patients with coronary artery disease, again, there is a J-curve. There is an increase in risk with value below 80, below around 75 millimeters of mercury. This J-curve was a bit attenuated after revascularization, suggesting that improvement in coronary blood flow may attenuate the increase in risk with lower blood pressure. These are just a couple of examples of either observational trials or post-hoc analysis of randomized clinical trials. We may include also results from post-hoc analysis of value trial or on target, which demonstrated that the J-curve exists, particularly for patients with coronary artery disease. However, we have to recognize the limitation of this post-hoc analysis. In fact, randomization is lost in this case. At the extremes of the curves, there is a small number of individuals and a very small number of events that reduce the power of the analysis. There are different risk characteristics of patients at the extreme of the curve, the possibility of reverse causality. The increase of risk is not because of reduction of blood pressure, but because these patients were more sick and had lower blood pressure. And there are different nadir of blood pressure values in different trials. So all these reasons can put some attention and limitation to the analysis of data. And probably we may advise not to go too low, particularly for diastolic blood pressure in patients with coronary artery disease, but for other disease we cannot be certain. But this is a problem that should be solved in the future. Third point, considering the benefit versus harm from treatment. As we said, lowering blood pressure may have some advantages. And this was also demonstrated in the SPRINT trial, apart from the problems of blood pressure measurement that we shortly discussed yesterday with unattended blood pressure that probably gives lower blood pressure in comparison with conventional office blood pressure measurement. However, there is no doubt that those with lower blood pressure had a better outcome. So it was calculated the potential benefits and risk of this intensive goal of treatment, estimating the death prevented and adverse event if this intensive blood pressure treatment goal was implemented in all eligible US adults. Okay, given the mortality rate observed in SPRINT, only 90 SPRINT eligible patients needed to be treated to an intensive blood pressure goal to prevent one death from any cause after this median duration of the study. And you can see that particularly in the elderly, those above 75 years, death prevented were 67, reaching the intensive blood pressure goal, and the number needed to treat was also low, 26. So a clear advantage. But at the same time, these patients had a greater incidence of hypotension, syncope, electrolyte abnormality, acute kidney injury. So the conclusion was that if fully implemented in these eligible US adults, intensive blood pressure treatment could prevent more than 100,000 deaths per year. But the consequence of this treatment strategy could be an increase on severe adverse events. So we are to consider this balance, possible benefits, but also possible harm in these patients. And indeed, in patients with an age above 75, 80 years, reduced too much blood pressure may be dangerous. Of course, this may depend from the frailty of these patients. As this patient included in this trial, the Partage trial, that was held by Professor Benetos, in which it was observed that this frail patient institutionalized with cognitive reduction, cognitive dysfunction. Well, those who had treatment and for hypertension and achieved systolic blood pressure below 130 were those with less survival. So we have again to balance the benefit and the harm. And if we considered, according to a meta-analysis, the relation between improvement, reduction, prevention of events with greater reduction in systolic blood pressure and trend in adverse events, we can see that the lower the blood pressure, the greater is the incidence of adverse events. This means that before deciding to intensify treatment control and, for example, bringing the patient's systolic blood pressure below 130 millimeter of mercury, rather than leave it some millimeter of mercury above that cutoff, the physician should carefully evaluate the characteristic of the individual patient: cardiovascular risk, personality, target organ damage, the structure of the physician-patient relationship, follow-up visit, facilities, and decide accordingly. As we said several times, Professor Ciuffi said several times, we are treating patients and not numbers. I think you agree on that. Last point, the residual risk. The residual risk and the need of early treatment. The residual risk means the risk that remain after effective blood pressure reduction and cannot be a risk that cannot be reduced by antihypertensive treatment. This is a phenomenon well known. We have many examples. More than 20 years ago in Sweden, it was observed that those patients that during treatment reached this blood pressure goal, in comparison with those that were normal, at that time it was considered normotensive, had the same blood pressure values. Well, those who had the same blood pressure but reached by treatment had higher cardiovascular risk. The probability of having an event was greater. This was confirmed by several studies. Now, this residual risk has been evaluated also in meta-analysis, subdividing patients according to the basal cardiovascular risk from low to high to very high. Certainly, reducing blood pressure by 10 millimeters of mercury reduce the cardiovascular risk, and in absolute term, the number of events prevented, the reduction of absolute risk is greater at those at baseline very, very high risk, but also the residual risk is greater. So with more advanced disease, you may have more event prevented, but also more residual risk. So the patients remain at a very high risk. And this should be considered and should be explained. Certainly, it is possible to have other risk factors to be controlled. We may reduce more blood pressure. We may consider the variability of blood pressure during time and so on. But one important factor of residual risk is the organ damage at the level of the heart, of the vessels, at the level of the kidney. And we may also quantify this risk. For instance, if we consider changes in left ventricular mass during time in this sort of meta-analysis, of course, those that during time had the persistent or left ventricular hypertrophy, or even a development of left ventricular hypertrophy, had more risk than those who had regression within normal limits of left ventricular mass. But the risk, you can see, is a bit higher than those who had the persistent normal mass during follow-up. The follow-up of these trials, similar trials, lasted up to 10 years. So there is a sort of residual risk even in those with left ventricular mass within limits. Comparing those with left ventricular hypertrophy regression to normal and those with persistently normal, never left ventricular hypertrophy, there was a trend favoring never left ventricular hypertrophy. Also in this evaluation by the Perugia group, it was at the end concluded that cardiovascular risk is higher in patients with left ventricular hypertrophy regression than in those with persistently normal left ventricular mass. A second example is with albuminuria. In this trial, it was evaluated in patients included in the on-target RASCENT trial, the change in risk in the event rate with either a reduction in albuminuria or an increase in albuminuria. Well, you can see that considering these patients according to baseline albuminuria from very low to high up to the level of proteinuria, we have this event rate reduced during treatment with decrease in albuminuria greater than 50%. This the event rate in these low-risk patients. if albuminuria was not reduced, on the contrary, was increased, this was the event rate, higher, of course. But if we consider this other group at increased risk, increased albuminuria, well, you may reduce albuminuria, but the event rate is quite high, not only higher than those at lower risk, but even higher than the event rate of those who increased albuminuria if they were at baseline low risk. So baseline low risk, there is always a reduction with reduction of albuminuria, an increase with increase of albuminuria. But if you are baseline at high risk, the reduction is always with an event rate higher than those who had baseline low risk, low albuminuria. So in my mind, this means that you have to start treatment very early. So my conclusion is the lower better, the reduction of blood pressure. Sometimes you have to consider not to make harm. You have to control your patient. You have to consider the pathophysiological and clinical characteristics. The earlier the better, in my opinion, probably always the earlier the better. Because the most effective strategy to reduce risk is to prevent the development of high cardiovascular risk situation with an earlier intervention. Now, the challenge is to set the most appropriate time. What is not too early and not too late? This is what we have to decide in our patients. I thank you for your attention.
Great as usual, Enrico. It's you get it. The questions from the audience regarding the arginine. Is there any rule for arginine to treatment?
Arginine treatment?
Yeah, in treatment.
You mean as a precursor of nitric oxide?
Yeah.
I cannot see you. I don't know. Stop share. I can make no. Okay. Anyway, I think that at present time there is no clear place for this treatment strategy. It's true, arginine is a precursor of nitric oxide, and nitric oxide is the mediator for endothelial function, and a greater availability of nitric oxide means better endothelial function. But the problem in hypertension, as in other conditions characterized by other risk factors, is that nitric oxide availability is limited by a mechanism of oxidation and not by availability of precursor of nitric oxide. It is the presence of reactive oxygen species that oxidate nitric oxide. Therefore, the availability is not possible anytime, and so is the main cause of endothelial dysfunction. So the precursor is there, but you can give what you want. But if this is not available for having a functional nitric oxide, this does not work. So at present time, there is no clear place.
Another question regarding the risk category of the patients. I mean, you said that those with albuminuria and those with diabetes and those with LVH, it doesn't differ in the effect of drugs. I mean, yeah. You have a number and you have a category. You could this table is you have a table reaching 130/40 or between 130 if it's a younger age. So you have an age and you have a category and you have a number. So if this is correlated with each other, there is category and the numbers and the patient himself.
You should try to correlate all this information, of course. I agree that, for instance, for albuminuria, you have to choose appropriate drug. And we know that RAS blockers are more effective than other drugs in reducing albuminuria. Our purpose is to reduce albuminuria, because in this way, particularly in patients with diabetic nephropathy, but also in general with reduced renal function, reducing albuminuria, we may have a better cardiovascular and probably better renal outcome. At the same time, we also know that reducing more blood pressure, we may reduce further albuminuria. However, the point is that if you start from a certain level of albuminuria, indicating a certain level of renal derangement, or a higher level of albuminuria, you always can get an advantage. But the advantage is, if albuminuria is quite high, is greater than 300 milligrams per deciliter, the advantage is much less than if you start with lower albuminuria. This indicates that you have to consider your patients and try to start as early as possible your treatment with appropriate blood pressure goal. So you have to put all together, in my opinion. Sorry, I don't hear.
You hear me now? Okay. Regarding the COVID-19, one important question: is it possible that people who take certain prescription, other drugs, have elevated risk if COVID-19 is there? I mean, regarding the ACE inhibitor ARBs, or you can increase the dose, taking drugs with these ACRBs doesn't affect the inflammatory process which affects the ACE genes. Can you finalize this point?
Yes, also yesterday we commented this. So far, we don't have an indication to change antihypertensive treatment. We know that if you reduce treatment, you may have a risk. You don't know whether changes this drug, the outcome of a COVID infection may be improved. So at present time, all the scientific societies recommend not to change treatment. I am convinced that shortly we'll have some epidemiological data that can inform us whether continuing treatment or stopping treatment or treatment with RAS blocker, without RAS blocker, has any difference in the outcome of this infectious disease. But so far, we cannot recommend any change of treatment, any different approach. For instance, another recent target of this virus, COVID, has been identified in DPP-4, that, as you know, is a target of anti-diabetic drugs. There is a very recent paper from the University of Miami indicating this as a very important target for attachment of the virus. But we don't know whether this drug that interfere with DPP-4, dipeptidase, may have any effect on the change of the history of this disease. We know very few information.
Finally, regarding the blood pressure variability issue, I mean, you said that you have to optimize treatment, lower blood pressure area. It doesn't affect you choose one drug over the others if you have, first of all, do you recommend to measure blood pressure variability patient to beat to beat, or office to office, or ambulatory, and then you decide how to get your drugs for the patients, or it doesn't recommend in the guidelines?
Well, the story of variability is a complex one. Of course, you may have a short-term variability within the day, or within the day, from day to night, or bit by bit, and also a long blood pressure variability. I mean, the changes in blood pressure control in different visits at intervals of weeks or months. we have more information on this second type of variability, long-term variability. Of course, if during time, sometime blood pressure is well controlled, sometime is not well controlled, then the cardiovascular risk is not well reduced. But the point is that is a problem of the drug you are using, or the problem how you take these drugs. I mean, poor adherence or better adherence. We don't know exactly what it is. Considering some studies that have evaluated short or medium-term variability, studies from Oxford, they suggested that calcium channel blockers may be more effective than beta blockers. But these results have not been confirmed by other trials. So at present time, we cannot say whether some drugs are more effective than others, apart from considering that we should use a drug with a prolonged duration of action that could protect for 24 hours or more. But we don't know exactly which kind of antihypertensive drugs may be more effective. And perhaps the use of home blood pressure monitoring may give some more information on this day by day or week by week blood pressure variability, and correct it on time at an early stage.
Thank you very, very much, Enrico, for this wonderful lecture and answering difficult questions. Regarding now the second talk in this session is by Costa. Yeah. Okay. Okay. After the wonderful lecture by Enrico, there's now another lecture by Costa from Greece. Difficult to control hypertension. Costa.
Thank you, Mohammed. Today I will discuss who has difficult to control hypertension. In other words, what would be the correct diagnosis, then how to improve the blood pressure control, what should be the appropriate therapy, and the last, I will close my presentation discussing the future direction. In terms of time, I will not discuss the malignant hypertension or the emergency urgency hypertension and the mass uncontrolled hypertension. Everyone agree that there are different and arbitrary terminology for potentially the same clinical problem. We have the term resistant hypertension with a prevalence of 5 to 30% in the overall hypertensive population. We have the term apparent treatment resistant hypertension with a prevalence 2 to 5%, resistant controlled hypertension about 20%, and lastly, the refractory hypertension, about 5% of the resistant hypertension. Despite this different terminology, we all agree about the adverse prognosis associated with resistant and difficult to control hypertension. In this prospective study from my center, we classified the patients in 4 groups: those who never been resistant, those with resolved resistant hypertension, incident hypertension, persistent hypertension at baseline and during follow-up. And patients with persistent hypertension was associated with 3-fold increased risk for cardiovascular events compared to those who never been resistant. According to the last European hypertension guidelines, resistant hypertension is defined when blood pressure is above the 140, above 90 for systolic and diastolic respectively, despite the appropriate therapeutic strategy, which should include a diuretic and RAS blocker with CCB. And also, there are two more requirements. The inadequate controlled blood pressure has to be confirmed by ABPM or home blood pressure monitor, and also we have to exclude various causes of pseudo-resistant hypertension, especially poor medication adherence and secondary hypertension. We appreciate in this slide the different hypertension phenotypes based on blood pressure control and numbers of antihypertensive medication. If the blood pressure is over 140 and the patient receives one or two drugs, we have the term of uncontrolled hypertension. If the blood pressure is uncontrolled, but the patient receives more than 3 drugs, 3 or 4, we have the resistant hypertension, and the term of refractory hypertension if the patient receives more than 5 drugs. Also, according to American Heart Association, even if the blood pressure is controlled, but the patient receives more than 3 drugs, then we have the definition of controlled resistant hypertension. Coming to the pathophysiology of resistant hypertension, we recognize that resistant hypertension is a complex disease where there is an extreme activation of renin-angiotensin system and also of sympathetic nervous system. Just a few words on the refractory hypertension phenotype, where in contrast to the classical resistant hypertension, where there is increased volume irritation, here there is no evidence of increased fluid irritation compared with patients with controlled resistant hypertension. Also, aldosterone levels are not higher, and there is no suppressed renin levels. And in this case, intensive diuretic therapy is not adequate to control the high blood pressure, and more research is needed in this area. So, if we see the large pool of uncontrolled hypertension, about 40 to 50% of all hypertensives are uncontrolled, we can distinguish some groups with significant overlapping. Pseudo-resistant hypertension, 5 to 20%, includes white coat hypertension, medication not adherence, under treatment, resistant hypertension, as well as secondary hypertension. For this reason, I think that the most appropriate term is difficult to control hypertension. That includes either patients with pseudo-resistant hypertension or resistant hypertension or with some types of secondary hypertension. Difficult to control hypertension represents a very mixed group of patients with target organ damage and cardiovascular or renal disease. From the spectrum, from resistant to difficult to control hypertension and vice versa, there are some issues that could be easily clarified. Accurate blood pressure measurement is fundamental for the definition of hypertension, for the definition of resistant hypertension. Exclusion of white coat hypertension is easy based on out-of-office blood pressure measurement. Also, to exclude the majority of the secondary cause of hypertension is not difficult. And also, we have to take into consideration to remove some causes which maintain high blood pressure, as the high salt intake, severe obesity, obstructive sleep apnea, and blood pressure drugs. Just a few words about the sleep apnea syndrome that is very, very common among patients with uncontrolled hypertension and patients with resistant hypertension. In these patients, just to remind you that CPAP therapy could result in a significant reduction in ambulatory blood pressure, but this effect was seen in patients with ABPM confirmed resistant hypertension who use CPAP for more than 5.8 hours per night. And most interventional trials in sleep apnea syndrome and also some meta-analysis have indicated that CPAP has only a modest effect on blood pressure levels. Of course, improves the quality of life, but the net effect on blood pressure is modest. And also, there is no clear evidence for preference for a specific type of antihypertensive drugs, and selection, even in patients with sleep apnea syndrome and uncontrolled hypertension, should be guided by the patient's cardiometabolic profile and associated clinical conditions. Everyone is familiar with some drugs that can induce difficult to control hypertension, non-steroid anti-inflammatory drugs, oral contraceptives, erythropoietin, and over-the-counter dietary herbal supplements. But I would like to emphasize the importance of some anti-angiogenic drugs, particularly those with VEGF blockaded. Nowadays, thanks to the successful treatment with new anti-cancer drugs, we observe some de novo cases of uncontrolled hypertension, or with cases with deterioration of previously well-controlled hypertension, and the underlying pathophysiological mechanism seems to be significant endothelial dysfunction, and in these cases nitric oxide donors should be the preferred choice of antihypertensive drugs, while we have to use very cautiously CCBs. And verapamil and diltiazem are contraindicated in this specific group of hypertensive patients. Coming now to say a few words about some issues that could be more difficultly clarified from in the spectrum of from resistant to difficult to control hypertension. Exclusion of primary aldo is an important issue. Evaluation and management of adherence and persistent medication is also of high importance. And last but not least, how to select the appropriate individualized therapeutic algorithm for this specific hypertensive group. The prevalence of primary aldosteronism is high among patients with resistant hypertension, range from 5 to 20, and even in some studies to 40%. Normokalemia is more common than hypokalemia, and less than 50% of diagnosed cases with hypokalemic were hypokalemic at presentations. And also keep in mind that aldosterone-renin ratio higher than 30 is suggestive but not diagnostic of primary aldo. Dietary sodium intake affects aldosterone-renin ratio determination. We know that beta blockers suppress more the plasma renin activity than aldosterone, resulting in false positive increase in the ratio, and also the RAS blockers results in false negative decreased aldosterone-renin ratio. Confirmatory test for the diagnosis of primary aldo is of high importance. Non-adherence to medication is a significant barrier to management of hypertension. Is widespread. We appreciate here that among patients with resistant hypertension, poor medication adherence is very common, from 30 to 80%. It's dynamic, it changes from day to day, from week to week. It is very difficult to detect. So it's something that we have to take into consideration when we have to manage the patients with uncontrolled hypertension. And I think that the best approach to improve medication adherence to our patients is a collaborative approach, to have a good contact with the pharmacist, with the nurse, with the specialist, but also to spend time to explain to our patients the importance of achieving the blood pressure targets, and also to inform the patient about the side effects, and to discuss with him all the issues related to the therapy. And coming to the appropriate therapy, of course, the guidelines recommend triple therapy by definition. And there is an open question, which is the appropriate diuretic, chlorothalidone and dopamine or hydrochlorothiazide. We know that chlorothalidone and dopamine maybe are more potent per milligram in lower blood pressure with a longer duration of action, but also without evidence of greater incidence of side effect. But coming to the outcome, there is no difference between thiazide and thiazide-like diuretic. What is important is to prescribe the adequate dose of diuretic, and in some cases of difficult to control hypertension, to combine diuretics, and keep in mind that loop diuretics are contraindicated when the GFR is less than 30. This is the algorithm for treating uncontrolled hypertension and for resistant hypertension according to guidelines. As a third step, as the next step after the triple therapy, the guidelines recommend, based on the standard pathway, to add spironolactone, 25 to 50 milligrams per day, or other diuretic, or alpha blocker, or beta blocker. And if the blood pressure remain uncontrolled, consider a referral to a special to the specific center, to the excellent centers for hypertension. Coming to the role, to the effect of MRIs in treating high blood pressure, in this meta-analysis from my team clearly shown that MRIs are effective to achieve blood pressure control, either in patients with resistant and without resistant hypertension. We see an important reduction in systolic and diastolic blood pressure, but on the other hand, of course, we have more discontinuation of therapy in the spironolactone and the Plerenor group compared to the placebo or to the other active comparators. And also, we have data from the RIHOTA study that also centrally acting drugs like clonidine is an effective approach. There is no difference in the lowering in systolic and diastolic blood pressure between clonidine and aldosterone in the RIHOTA study, but thanks to the flexibility of that we have with aldosterone, this is the preferred choice if there is no contraindications. And moving to the precision medicine, there is an interesting publication a couple of years ago, actually 1 year ago, in hypertension, that measuring aptoglobin in the urine and the aptoglobin-related protein, we can predict the response to spironolactone to our patients. And now, what we expect for the future? What about new antihypertension drugs in this difficult to control hypertension? What could be the contribution of renal denervation, the role of apps and sensors, and the precision medicine? In this very busy slide, we appreciate the different pathways that are under research to develop new antihypertension drugs. Unfortunately, we don't have some let's say, definite results. We expect what would be the contribution of sacubitril based on the results of the Paragon study that we discussed in the previous session. And also there is a lot of discussion about the activators of ACE2. This enzyme is it's very interesting in this area, thanks to the COVID-19 outbreak, since the SARS virus use this enzyme for the entry in the cells. But up to now, we don't have definite data. And also, there are some promising strategies to reduce blood pressure in uncontrolled hypertension by nanodrugs, liposomes, nanopeptides, in order to have some new approach to treat high blood pressure. And last but not least, the last indicated, we have a number of device-based hypertension therapies targeting neuromodulation to contribute in the control of blood pressure. The most promising one seems to be the renal denervation, and this story started 1 decade ago, but after the neutral or negative results of HTN3, there was a huge disappointment. Last year, we had publications from 2 in Lancet, 3 different publications in patients with and without antihypertensive medication by using different methodologies for disrupting the renal fibers, the radiofrequency energy, and also the ultrasound energy by using the spiral and the Paradise device, respectively. And thanks to these studies, the renal denervation is back on the track because since now we have data that renal denervation works in patients with antihypertensive medication 1 to 3, also in patients without receiving any antihypertensive medication, renal denervation achieved a clinically meaningful reduction in ambulatory and office systolic blood pressure. And just 2 weeks ago in the ACC, as we know, ACC was postponed, but it was virtually presented, and Professor Michael Baum presented the results of the pivotal study in patients with uncontrolled hypertension, naive of antihypertensive drugs. And this study was simultaneously published in Lancet. My center was participated, and actually it was first in the number of patients enrolled and randomized in this study. And we were very happy to see that in this study that has the power to prove that there was a significant reduction in 24-hour systolic blood pressure by 4.7 millimeter of mercury, and in the office systolic blood pressure by 9.2 millimeter of mercury, and a reduction also statistically significant and clinically meaningful in diastolic blood pressure. And also, what is important that this blood pressure reduction was evident throughout the 24 hours during the daytime and the nighttime in the renal denervation arm compared to the sum control, where there is no any difference. Of course, there are ongoing renal denervation programs by using different methodology, the spiral catheter, the Paradise ultrasound balloon, the peregrine by causing chemical denervation, and the Vexis renal denervation system. And of course, the hot question is, what are the potentially good candidates to renal denervation for hypertension therapy? Renal denervation, according to the pivotal study, could be a first-line therapy as alternative to medication in patients with grade 1 hypertension, mild hypertension. And in order in those patients with a high probability of being controlled with chemotherapy, in those patients who have a preference to renal denervation over drug therapy, or in those patients with drug intolerance to any antihypertensive medication or with poor medication to adherence. On the other hand, renal denervation could be as adjunctive to medication in patients with resistant and difficult to control hypertension in order to reduce the pill burden and to improve the blood pressure control in a synergistic way with the antihypertensive medication. So, dear colleagues, as a take-home message, managing difficult to control hypertension, I would say that it's essential to confirm diagnosis as a first step by exclusion of white-coat hypertension and secondary hypertension, to provide always lifestyle recommendation. This should be the first step. To verify medication adherence is very, very crucial. To prescribe appropriate use of type and dosage of diuretic, to add as a fourth line antihypertensive spironolactone or clonidine, and to refer the patient to a hypertensive excellence center. And thanks to the COVID-19 outbreak, the 7th official pre-ESH Congress Satellite Symposium that every year organized in Athens, an update on difficult to control hypertension and related comorbidities was postponed, and the new date is 11 to 12 September 2020. I hope that until September we will have finished with this pandemic, and we'll be more than happy to see many of the French physicians from Egypt to attend this meeting in Athens to learn more about the management of difficult to control hypertension. Thank you so much for your attention.
Okay, thank you, Costa. Great as usual. You raised several points for discussion. In the last few months, there is a review article in JACC about the primary hyperaldosteronism. A lot of tables, investigations For the audience here, do you think that it's if I'm a doctor thinking about this, is it depending on urine or doing VMA, and this if it's high you do CT or doing adrenaline, noradrenaline? How can you, in a simple way, think about primary hyperaldosteronism?
This is a very, very hot issue, very, very difficult in the practical management. I would suggest that if we have a patient with difficult to control hypertension or resistant hypertension, of course I have to take into consideration the possibility of the primary aldo. If this patient has high, let's say, low serum potassium, of course, there is an indication, but as I mentioned previously, even normal serum potassium levels does not exclude the possibility of primary aldo. In this case, if I have such a patient with the possibility of primary aldo, I would try, of course, to estimate the aldosterone-renin ratio. This after goes out of diuretics, after goes out of RAS blockers, because these drugs are also excluded the beta blockers, because these drugs affects this ratio. Only CCBs are the neutral in their effects in estimate this ratio. If the aldosterone plasma renin activity ratio was high, over 30, in this case, I would go on, I would suggest a CT or an MRI of the adrenals in order to detect some tumor there. This, I think, is the most practical approach. Not everyone patient to be screening for primary aldo, but on the other hand, if you have difficult to control the high blood pressure despite the appropriated therapy, despite the, let's say, the assessment of medication adherence, yes, there is space, there is a room for further clarification of this possibility.
If you have a patient taking, usually all the patient taking dual combination therapy from the beginning, dual therapy. So which patient profile, ACE or ARBs with diuretics or ACE or ARBs with the calcium channel blockers? And when you shift to triplet therapy for these patients, after you reach the maximum dose of the dual combination therapy, or you choose according to the response of the patient in general?
Yeah, thank you for this question. Actually, I think that the best approach is to individualize. If you have, if your patients receive, let's say, a triple combination with not maximum dose, if I am very close to achieve the blood pressure targets, I would increase the dose to go to the maximal tolerated dose. But in some cases, we have difficulties to achieve the maximal dose due to the edema. Let's say if we go from 5 to 10 milligrams of amlodipine, maybe we have more edema, or may have some metabolic disorders increasing the dose of diuretic. In this case, maybe I would accept the tolerating dose, and then to go to the addition of the fourth step, going to the spironolactone. Personally, I prefer in males eplerenone, although I know that it is not so strong as aldosterone, but it is better tolerated in terms of side effects. But keep in mind that eplerenone is better to be prescribed twice a day instead of once a day. It is more effective.
Okay, regarding if there is no response for a second, there is a speculation. I know that the Paragon is not effective in the heart failure, but you can you try to take this combination at a trial for the patient not responding to treatment?
I think that if the patient receives a triple combination, maximum tolerated dose, and if you add spironolactone or clonidine, depending on the profile of the patient, and the blood pressure remains high, particularly patients who have some symptoms of heart failure, dyspnea, fatigue, yes, in these cases, I think although it is let's say, off-label, I think, practically speaking, I would also suggest the combination of sacubitril in specific cases in an individualized approach, not for everyone.
You know, I did in the last 2-3 years ago. I did a lot of renal denervation, like the European side that was successful in those diagnosed. But now after the Simplicity 3, we stopped doing. But now with the new trials saying that it's okay. But I think I need your opinion, you and Enrico. Is it the failure of this, the shame itself, or we don't know the mechanism of renal denervation, or we don't know the etiology of how to ablate? Is it neuromodulatory, or it is we have to make a local drug inside the renal vessels? How can this story run up again?
No question that there are a lot of questions that we have to answer. But at least now we have solid evidence that renal denervation works. After HTN3, there was a huge doubt for if renal denervation could achieve blood pressure reduction. For this reason, we moved, in order to exclude medication adherence and other issues, to the patients not receiving any antihypertensive medication, and under a strict methodology by using some ablation. It is not easy, let's say, to randomize patients, hypertensive asymptomatic patients, to renal denervation or to some procedure. And now, thanks to these studies, by using different technologies, different catheters, ultrasound or frequency ablation, we have consistent results that renal denervation could achieve a clinically meaningful, not huge reduction in blood pressure, but average a reduction of 10 millimeter of systolic blood pressure in office blood pressure, 5 millimeter in ambulatory, and we know based on data from meta-analysis in the pharma trials that this would be the result into 20% reduction in the cardiovascular event. Of course, there are many questions. The renal denervation procedure remains blind. We don't know if we have achieved adequate ablation during the procedure. We have to wait the 3 months period to see if the renal denervation was effective. I agree with you, but also we have now a better understanding about the distribution, about the location of the renal fibers, about the pathophysiology, and I am optimistic that in the near future, we will have more data. And as a physician, I am happy to have one more tool in our hands, along with the lifestyle modification, along with the very effective antihypertensive medication. In some cases, we will have also renal denervation to contribute in the better blood pressure control.
Okay, Enrico, can you add this? Yes.
Oh, I think I completely agree, but Costas is an expert. He's worked with this renal denervation technique. Certainly, the first negative study had a lot of limitations in the enrollment of patients, in the evaluation of patients, in the performance of the denervation, and so on. And now it seems that with an appropriate design of the study, with good researchers, the results are much clearer. And there is on average, some reduction of blood pressure, renal denervation. The point now is, Costas, you can answer this question possibly, at least in part. Which are the patients that more easily may respond to the treatment? Because this is the point. While with drug, you can give a pill and then change the pill if this does not work. Then you are performing a denervation, which is an invasive procedure. So it is much better to know which are the patients that more easily may have an advantage from this procedure.
This is $1 million question, Enrico. We don't know, based on the clinical phenotype, who will be the responder. What all the studies have shown that the higher the baseline systolic blood pressure, the greater the possibility of being a responder. But also this would be thanks to the regression to the mean phenomenon. Also, the younger the patients, the better the response. In the initial studies, there was some suspicion whether patients with isolated systolic hypertension could be ideal candidates. But new data shown that renal denervation has the same effect. Up to now, no way to know in advance who will be responder. But I think with the improvement of the technique and with the better understanding of this pathophysiology, and also with the enrollment of more patients, we will make new analysis, and maybe we will be able to identify the appropriate phenotype. This is very, very important for selecting the appropriate patients for doing such an invasive procedure, although it is very important to mention that up to now, there is no concerns about the safety of renal denervation. And this is very, very important.
Okay, thank you very much. We have to move to the next session, Abbott Symposium now. We don't have time because you have a lot of discussion. So we have to move the second because you have two sessions, one Abbott and one debate. So it's two hot topics now.
It is now the Abbott Symposium. It is my pleasure to introduce my dear Professor Mohammed Sobhi to discuss how do dipyridamine and non-dihydropyridamine calcium channel blockers differ.
Thank you very much, Professor Tariq, for a nice introduction. It's thanks to Abbott Symposium for the Abbott Group and Dr. Sally for making with me these presentations. When you decide to make this presentation, we have a lot to do. Is it possible to speak about nowadays non-dihydropyridine or dihydropyridine? So I make this title, not all calcium blockers are the same. Actually, the global cardiovascular disease account for approximately 17 million deaths a year. Egypt from top risky countries, as you all know. For these complications of hypertension account for about 9.4 million deaths every year. But hypertension is not alone. Hypertension usually, as we said by Enrico, with the risk category, there's diabetes, with the hypertension, coronary disease, myocardial infarction, finally congestive failure, and sometimes we have dyslipidemia, renal disease. So it's not usually alone hypertension, usually with different diseases as well. The optimal treatment of any coronary artery disease should ideally include a regimen. This reduction of myocardial demand through the heart rate and blood pressure reduction, increase myocardial oxygen supply through coronary vasodilatation, and also provide protective therapeutic effects through at the time of maximal risk for development adverse cardiac events. So verapamil or HCl, this drug since a long time, and the mechanism of action of this drug is to delay conduction, the EV node, restoration of the sinus rhythm and normalizations of ventricular frequency. Normal heart rate is unaffected or lower slightly, and it possesses well-developed antiarrhythmic effects, particularly in the presence of SVT, and also reduction of myocardial oxygen requirements. It blocks the transmembrane influx of calcium ion in cardiac muscles, decrease afterload, decrease myocardial oxygen requirements. It's also in use in patient with for coronary vasodilatation, particularly in patient with coronary vasospastic angina, because it relaxes the coronary spasm, it increases the myocardial perfusion, and it blocks the calcium effects in the smooth vascular muscles of the coronary arteries. Also in the peripheral vessels, it lowers the peripheral vascular resistance, no rebound, increase in heart rate, no blood pressure is not affected, it increases myocardial oxygen requirements. When you come to studies about the use of this verapamil SR versus trandopril-based strategy and versus atenolol as well, this combination of trandopril-based strategy, verapamil, versus atenolol hydrochlorothiazide-based strategy, it's 1100 in those kind of patients. There is similar results observed in the treatment strategy for all-cause mortality, for the first events, and also for non-fatal myocardial infarction and non-fatal stroke. And this study is called INVEST study. In stable angina patient, the verapamil HCl decreased the number of anginal episodes per week, if reversing the single blind versus double blind drugs, even with a 320 milligram versus 480 milligram. The same in stable angina, it decreases relative reduction of 68%, reduce frequency of angina, and decreasing the number of nitroglycerin tablets consumed by 60.7%. The verapamil HCl, when you're comparing stable angina for the sinus rhythm, the most suitable for the calcium channel blocker for monotherapy in patient with chronic stable angina, as you can see, the comparing with verapamil versus dihydropiridine versus short-acting dihydropiridine, which nifedipine. So the number of attacks of angina, the glyceride nitrite consumption, and maximal working capacity are significantly reduced when using verapamil HCl. When verapamil HCl slow release is ineffective, as nifedipine, propranolol in patients with either fixed variable coronary reserve, either symptomatic or silent, as you can see in this study, in stable angina, SR is more significant for reduction in the fixed coronary reserve and in variable coronary reserve patients. This is a study as well for using verapamil HCl SR monotherapy versus amlodipine plus atenolol combination therapy, was more effective than amlodipine monotherapy in decreasing ambulatory myocardial ischemia during the hours of 6 a.m. 12 noon, as we can see here for the comparison of isoprene SR. This is for stable angina. Regarding this unstable angina, actually we have also studies comparing this verapamil versus placebo versus isopten versus nitrate heparin, significant reduction in total number of ischemic episode when using diltiazem for unstable angina patient. For silent ischemia, verapamil HCl SR is more effective than propranolol in reducing the number of episodes of silent ischemia. It would exhibit potent effect on coronary smooth muscle tone, which makes it effective in preventing and resolving coronary vasospasm. So it's very effective in coronary vasospasm in patients with silent ischemia. So in stable, unstable, silent ischemia, and also in post-myocardial infarction. This study comparing verapamil HCl SR will be used as a secondary prophylaxis after infarction. These were patients treated with beta blockers compared with placebo-treated patients. They calculated reduction of mortality by 22% and reduction of re-infarction by 27%. For the DAVID 1 and 2, verapamil HCl SR significantly reduced deaths by 22% and major events by 21% and re-infarction by 27% for inpatient without heart failure after myocardial infarction. Very important, without heart failure. Regarding the measurement of plasma norepinephrine, heart rate, and sympathetic activity, these are increased with amlodipine versus placebo versus verapamil HCl, which is after placebo, the rate was 68 beats per minute, but the heart rate was lower with the verapamil than with amlodipine, 65 versus 69 beats per minute. So a significant reduced norepinephrine heart rate with verapamil versus amlodipine. Regarding the post-infarction level for the norepinephrine as well as the heart rate, which were distantly lower with non-dihydropyridine, which is verapamil, calcium blocker, than with dihydropyridine with DHB. As we can see here, this DHB long-acting dihydropyridine and non-HDB with non-dihydropyridine. This is the norepinephrine heart rate is decreased significantly, and the plasma norepinephrine. So this is in post-infarction is very, very important to use this drug. In essential hypertension patient, what will be the difference? The verapamil SR had the highest TP ratio among currently used. It is 82%, is trough to peak ratio. Amlodipine is 63%, lazidipine is 62%, diltiazem is 51%, and isradipine is 44%. So the expert FDA stated that in control studies where the treatment of hypertension associated with the decrease in mortality and or stroke, the treatment regimen used properly retain most of their peak effects at their troughs. So this is why verapamil is very effective, because of this stuff peak ratio in essential hypertension patient in comparing with amlodipine, lazepine, laldiazem, and isradipine. Also in essential hypertension, this is for the ambulatory blood pressure monitoring the control. If this is the systolic blood pressure, and this is the diastolic. This is placebo, and the red is enverapamil. As we can see, there is significant reduction of the systolic blood pressure for 14 hours of the 24 hours, and also in diastolic also 24 hours enverapamil. So it's more significant throughout the day, 14 hours systolic and 24 hours of diastolic, as compared in ambulatory is comparing with placebo. In Everest study, verapamil SR, this is 10,200 hypertensive patients and 2,300 general practitioner doctors followed these patients for 4 to 5 months. What they found when you take this drug, verapamil SR, they found that the 85.7% there is responders for these patients rather than the placebo patients. So in arrhythmia as well, this is very effective in SVT, as we can see. Now with narrow complex is very effective to reduction of SVT patient with the guidelines. Verapamil 80 milligram is effective versus adenosine. Adenosine group, adenosine plus verapamil, found that more effective reduction of the with 80 milligram intravenous injection, or with 80 milligram tablets, decrease the incidence of paroxysmal supraventricular tachycardia, even with intravenous adenosine. Then come to the important point regarding the kidney dysfunction, because there is a claim of the nephrology usually which calcium blocker can be used in kidney dysfunction. This is the systematic review of randomized trial of dihydroprotein calcium blocker and non-dihydroprotein in hypertensive adult proteinuria. As we can see, with non-hydroprotein, the MA and proteinuria are significantly reduced with using non-dihydroprotein rather than dihydroprotein, either short-acting or long-acting. The selectivity index as well of proteinuria was reduced after 8 months of treatment. So what are the guidelines saying about hypertension diabetic patients? American Diabetes Association, ADA, 2009, National Kidney Foundation, 2009, and GN7 recommended starting with the ACE inhibitor, then add non-dihydroprotein calcium blocker in hypertensive diabetic. This is very, very important if you use combination therapy in such kind of patients. What about the clinical practice guidelines in hypertension and antihypertensive agent in chronic kidney disease? As we can see, this is the calcium channel blockers, dihydroprotein, non-dihydroprotein, the renin-angiotensin system ACE and inhibitor and ARBs. And this is the beta blockers, selective, combined, and all beta blockers. No effect of these beta blockers, no effect of dihydroprotein, and only effect on the chronic kidney disease, decreasing proteinuria by non-dihydroprotein, which is laldiazem or verapamil, or ACE inhibitors, which produce slow progression of CKD and decreased proteinuria, and ARBs, which make also slow progression and decreased proteinuria. This is only the drugs which can be used as antihypertensive drugs with proteinuria. Diuretic has no effects, alpha blocker has no effects as well. So this is very, very important in such kind of patients. And finally, this is table differentiating between dihydroprotein, which is vasodilated calcium blockers, and phenylalkylamine with modulator calcium, which is verapamil. In hypertension, both the same. In angina, it's only vasospastic, but in verapamil, in effort angina, makes it vasospastic. Supraventricular tachycardia, hypertrophic cardiomyopathy, only non-dihydroprotein. Myocardial infarction in the absence of heart failure, only non-dihydroprotein, which is verapamil. Atherosclerosis can be used. So verapamil can be used in all these indications: hypertension, angina, effort makes it vasospastic, supraventricular tachycardia, arrhythmia, hypertrophic cardiomyopathy, myocardial infarction, absence of heart failure, and finally atherosclerosis. So who may benefit more from verapamil alone or in combination with RAS combination, which is then from ARBs? other than ACE inhibitor is calcium channel combination. Number one is patient with diabetes and metabolic syndrome. Number two, patient with proteinuria or coronary kidney failure. Number three, patient with coronary artery disease in absence of heart failure. Patient who need potent antihypertensive agent without compromising quality of life, 80 milligram or 240 millis stories and intravenously for emergency. And thank you very much, and looking for that questions.
Thank you, Professor Sobhi. You summarize most of the data regarding the cardiovascular benefits of and renal benefits of verapamil. I want to stress on one point that the short-acting calcium channel blocker nifedipine is prohibited for hypertension and for coronary artery disease. And there is a lot of trials using verapamil in patients with coronary artery disease, whether chronic syndromes or post-MI. Still, the guidelines recommend verapamil if beta blockers not tolerated. In spite of a lot of trials, you mentioned the benefits sometimes superior than the beta blocker. What's your comment about this? Yani? Still, the guidelines recommend the verapamil after beta blocker if beta blocker are not tolerated. What is your?
No, I think the guideline have been changed now. You can add to me that the current website is class 1A in hypertension with coronary artery disease and CKD and diabetes. It's class 1A, but only in these three indications. If you have a hypertension, coronary disease, hypertension with CKD, hypertension and diabetes, but not in others, as in hypertension. Enrico, can you add to this?
Professor Costa.
Yeah, well, I absolutely agree with your answer, but if I could ask some question to Mohammed. First of all, thank you so much for your excellent lecture. Many hypertensive patients also receive statins for the treatment of high cholesterol levels. Are there any concerns with the use of verapamil in some types of statins, specific statins, or no?
No, I think there is some claim about atorvastatin, the beginning that this can make some drug interaction between atorvastatin and verapamil, but you should be take care of this. Yes, you're right, but not other statins.
Thank you.
Well, I want to say that well, we have been using verapamil since many years with satisfaction. Of course, there are some side effects that may limit their use. In our experience, for instance, the most common side effect is stypsis, constipation. Constipation is, for some people, is a very disturbing side effect. Then, of course, according to the mechanism of action, there is a strong effect on the atrioventricular node, so this should be checked regularly. From one hand, this may be useful as an antiarrhythmic effect, but on the other hand, it may prolong PR interval, and therefore this should be checked. But in general, this is a very good drug that probably nowadays is used less than what it deserves. And this may depend from the fact that as a vasodilator, it may be a bit less potent than the hydropyridinic drug. But the combination of the effect on peripheral arteries and the heart may give the same reduction in blood pressure. And some patients may certainly have some advantage in addition to patients with coronary artery disease, in addition to patients with nephropathy and albuminuria. So I think what you have reminded and you have so clearly demonstrated is something that should be kept in mind and to use more this drug that has been also used in some large clinical trials. The INVEST study, for instance, had verapamil, and they found that it was very effective, at least as effective as a beta blocker or other drugs.
Can I add to this
question? There is a question from the audience.
Sorry, I have to make the constipation before you have the question. Regarding constipation, is not there if the patient is titrated up in the first week. It's very important. Yes, you are right about constipation, but you have to up titrate. If you up titrate, there is no constipation. Regarding the PR, yes, you have to follow your patient by ECG. This is very important because already, if you have a beta blocker already, you have to face. Yes, Tarek.
I think the constipation can be also a side effect of other calcium channel blockers, with individual variation for constipation. The question from the audience about the maximum dose of verapamil in patients with CKD.
It's 240. You know, it's measured. It's 240 or 320. You can make it up to this. It's one trial showing that, but you can make it more. But depending on the blood pressure, but you can make it up to 240 according to the heart rate, according to the PR interval.
Oh, I think when we use verapamil, we have to be cautious with the drug-drug interaction, especially if the patient is receiving digitalis, because the verapamil decreases the renal excretion of digitalis and may increase its level. The combination between verapamil and beta blocker, is very cautious. What's your comment about this combination?
Yes, it's very important to look to your ECG, the patient. If his heart rate is slow, don't give this drug. But if it's not slow, you have to give this drug, particularly in fixed threshold angina and mixed threshold angina. Nifedipine or amlodipine only used in vasospastic angina in such kind of patients, and not used in post-myocardial infarction. But you have to look to the ECG and the regular ECG follow up for the patient, maybe for the beginning and then after 1 month, something like that. But you have to, if there is bradycardia, you have to decrease the dose of verapamil. This is important.
My question about if the patient with chronic stable angina and intolerant to beta blocker, you give to control the heart rate, you give verapamil or ivabradine?
No, not for chronic patients. For the coronary patients, I think the best is to give verapamil, because there is the verapamil is only to decrease the heart rate, and that's it. It's not related to the coronary itself. So ivabradine is used in inappropriate tachycardia, but it's no proof for a signified trial in coronary artery disease. It's only in heart failure patients. So I think ivabradine is only in such kind of patients. So we have to use verapamil instead of this, because already we have the data. Regarding the hypertension, I have already just looked to the website for the hypertension. Yes, for the hypertension dose is 240, maybe up to 480, and this is the maximum dose you can give. For impaired renal function, there's no effect in.
If I can make a short comment.
Professor Enrico.
Yeah.
Okay.
Can you hear?
Yes.
I found interesting the observation on norepinephrine, that verapamil can reduce, in fact, the concentration of norepinephrine.
Yes.
This was one of our first study many years ago. I was young, and this was I was keen of this dosage of catecholamines, and when we found this result, we were very happy. We compared verapamil with nifedipine, slow release, short release. Nifedipine induced an increase of norepinephrine, while verapamil reduced this, and this was a very interesting difference. As far as the issue of vasospastic angina is concerned, I want to remind that Attilio Maseri, who discovered vasospastic angina, first used verapamil to demonstrate that calcium channel blockers can improve this situation. And in fact, For instance, it's increased metal in China. This resulted very effective, very, very effective. Verapamil, more than the hydropyridine, calcium channel blockers.
Yeah. So you are responsible for this study at the beginning.
All the study, all the studies.
There is a lot of discussion about this topic, but for the shortage of time, we have to close this session and to the another transfer to another session. Thank you, Professor Sobhi. Thank you, Professor Enrico, and thank you, Professor Costas.
Thank you.
Thank you.
We have start.
Yeah.
Okay. Now we start a debate session. There is a lot of debate about the use of beta blocker in hypertension, in coronary artery disease, and it is my pleasure to introduce Professor Costa to speak about the beta blockers are not the first choice for treatment of hypertension. Welcome.
Thank you so much, Tarek. Always to discuss about the role of hypertension in the management of hypertension is challenging for many reasons. First of all, not forget that beta blockers belong to those drugs, along with ACE inhibitors and statins, that have changed the prognosis and saved lives of millions of cardiovascular patients worldwide. And for this reason, James Black received the Nobel Prize award 3 decades ago. Second, for the therapy of heart failure, beta blockers are considered as class 1 level of evidence aid. Is fundamental for the therapy of heart failure along with ACE inhibitors. And also in patients with coronary artery disease, actually with chronic coronary artery syndromes, according to the revised European guidelines, beta blockers are recommended for first step therapy in patients with stable coronary artery disease. What about beta blockers in hypertension? What is the rationale for this debate? Beta blockers were recommended as first step therapy on hypertension by all guidelines, American and Europeans, up to beginning of year 2000. Recently, several guidelines have removed them from this position for a variety of reasons. First of all, beta blockers do not have evidence of cardiovascular protection in placebo-controlled randomized outcome trials. Second, their protective effect has been found to be less pronounced than what the other antihypertensive drugs have done in some trials. And the number of large-scale meta-analyses performed in the last 2 decades report that overall these drugs provide less reduction of cardiovascular events, stroke and death than drugs from other major classes for a similar or almost similar reduction in blood pressure. Let's see in more details all these concerns. First of all, are the beta blockers effective antihypertensive drugs compared to placebo? We have data from this large meta-analysis, very well known, in 2009 in BMG published, showing that beta blockers compared to placebo, they can reduce the blood pressure and reduce the cardiovascular event. Also, from the Cochrane analysis, beta blockers versus placebo was effective to reduce the all-cause mortality and the risk for stroke and coronary artery disease. But of course, their use were associated with a number of adverse events. And recently. Kostas Tomopoulos, who has done a lot of work within the field of meta-analysis in the last 5-10 years, now prepare a new meta-analysis examining the role of beta blockers in different clinical trials. He included all trials together. Also, we separated trials on hypertension only, on myocardial infarction, on HF, and also we excluded trials with heart failure and the myocardial function. And we estimated what are the effects on beta blocker versus placebo or no treatment, or less intense, not beta blocker based therapy. This is the first time that such a meta-analysis was performed, and we have this manuscript is now submitted for publication. It's unpublished data up to now. And we see here, if we focus as only in hypertension trials, that beta blockers compared to placebo was superior for heart failure, for stroke and cardiovascular disease, and also for stroke, coronary artery disease, and heart failure, where there is no difference compared to placebo or to no treatment regarding the all-cause death or the cardiovascular death. This is one limitation of the beta blocker compared to placebo. Let's see now what are the cardioprotective effects of beta blocker compared to the other classes of antihypertensive drugs. Also, based on the Cochrane analysis on beta blocker on hypertension, if we compare beta blocker versus placebo, as I mentioned previously, clear difference in favor of beta blocker. But if we go in the comparison of beta blockers with diuretics, beta blockers versus calcium channel blockers, or beta blockers with renin-angiotensin system inhibitors, we see that the reduction to cardiovascular events is less with beta blockers compared with the CCBs or RAS blockers. So, in summary, beta blockers seems to be superior to other drugs in patients with coronary artery disease, is inferior to calcium channel blocker for stroke prevention, and also is superior to calcium channel blocker in prevention of heart failure. And in this, in another meta-analysis published a couple of years ago by Thomopoulos, Parati, and Zakenti, direct comparison of beta blockers versus other class of blood pressure lowering drugs on 7 major outcomes: stroke, coronary heart disease, heart failure, and the composite of them. We see here that beta blockers was inferior compared to the other antihypertensive medications, and equal with this is with the yellow color, means no difference in the protection. And as it is expected, calcium channel blockers were superior for stroke prevention and for all-cause death. And in this paper that now it's under submission, also in hypertension trials, beta blocker was inferior compared to the other antihypertensive drugs, and also inferior compared to other drugs regarding the reduction in all-cause death. On the other hand, apart from this, let's say, not so protective effects of beta blocker for cardiovascular events compared to the other class of the hypertensive medication, use of beta blocker is associated with a number of adverse effects, and also a lot of mechanisms have been suggested to explain this less protective effect of beta blocker. Increased insulin resistance, the reduction in heart rate. We know that increased heart rate, and the new hypertension guidelines clearly state that a heart rate over 85 beats per minute is a risk factor for cardiovascular event. But it's an open question how low should be the heart rate in order to have additional effect. What should be the incremental effect of heart rate lowering by beta blocker apart from the blood pressure lowering effect? It is not clear. Also, we know that beta blocker increase the central blood pressure, decrease the peripheral flow, and increase the return waves. And on the other hand, we know very well that the majority of the previous studies which were used in all these meta-analyses were based on the use of atenolol. And we know that atenolol is an old drug with a short half-life, 6 to 9 hours. That means that it has to be prescribed twice a day. And also, there are some concerns about the route of elimination. For this reason, 1 decade ago, the reappraisal of the hypertension guidelines, as well as the 2013 European guidelines, clearly saying that beta blockers are not an homogeneous class. And maybe vasodilated beta blockers, such as carvedilol and evicolol, appear not to share some of these negative properties described for other compounds, and particularly for atenolol. On the other hand, we have to keep in mind that in the everyday clinical practice, we manage different hypertensive phenotype. We have the young hyperenergic hypertensive patients, we have the obese metabolic hypertensive patients, or the elder hypertensive with many comorbidities. So we have to manage in a different way all these patients. And also to take into account the quality of life of these patients, and we know that beta blockers are associated with side effects, in particular with erectile dysfunction. That is something that we have to take into consideration. For all these reasons, the guidelines, here is the American guidelines issued 3 years ago, where for initiation of drug therapy, first-line therapy agents include diuretics, CCBs, ACE inhibitors, or RBS, but not beta blockers, in line with the British guideline we have already done a couple of years ago. What is the position of the European guidelines that was released in 2018 in the Barcelona meeting? Of course, the main issue is to achieve the blood pressure control. For all patients, try to go below 140, below to 90, and in those younger than 65 years old, if tolerate, to go below 130. But we are not happy with the high rate of uncontrolled hypertension. And many factors have been involved in this poor blood pressure control. Efficacy of pharmacological therapies, physician inertia, patient medication adherence, healthcare system deficiency. All of these factors contribute. But I think one factor that has many, that is responsible for this poor blood pressure control is the wrong antihypertensive therapies, strategies that we have suggested all this the previous year. And now, in order to improve the medication adherence, and just I put these lines to emphasize that the new guidelines, medication adherence is cited 87 times, while in the previous edition is cited 37 times, an increase by more than 135%, reflecting the importance of medication adherence and how to improve medication adherence just by simplifying the therapeutic algorithm. For this reason, the current guidelines recommend combination therapy for most hypertensive patients as initial therapy, class 1 level of evidence A. And in this different strategy, we don't discuss which is the first line therapy. We discuss that for the majority of patients, we recommend single pill combination for most therapy. Of course, we recognize that all antihypertensive drugs, all antihypertensive classes, including beta blockers, have demonstrated effective reduction of blood pressure, effective reduction of cardiovascular events in randomized controlled trials, and thus are indicated as the base of antihypertensive treatment strategy. and beta blockers could be part of this therapeutic algorithm. If we prescribe monotherapy, because the guidelines recommend combination therapy, single pill combination therapy for the majority, for most, but also the guidelines give space for some type of monotherapy in low-risk patients, grade 1 hypertension, in very old or frail patients. And for beta blockers, we recommend to be prescribed only in case that hypertension is associated with heart failure, with coronary artery disease, with angina, post-MI, atrial fibrillation, or if you have a young hyperadrenergic woman or guy to reduce the high heart rate. Why beta blockers are not participated in this combination? First of all, for practical reasons. The only widely available combination as a single pill are the combination of RAS blocker with diuretic, a RAS blocker with CCBs, available with higher rates of dose, facilitated flexible prescribed titration from lower to the higher dose. This is not the case for beta blockers. Of course, if we have a patient, hypertensive patients with coronary artery disease, then guidelines clearly state that beta blockers should be part of this combination therapy. So, in summary, a take-home message, my messages are very clear. Two messages. Beta blockers in hypertension are not first-line therapy, but they are still alive and here. But also the most important message, try to treat the patients and not only blood pressure numbers. Thank you so much for your attention.
Thank you, Professor Costa, for this excellent presentation. And we will now shift to the contra by debate and by the end discussion. Professor Dr. Sharif Wahdi, Cardiology, Annex University. Welcome, Professor Sharif.
Thank you very much, Dr. Tariq, for this introduction. And Dr. Costa, he said all of my talk. All the presentation have been said by Dr. Costa. It's a great honor to be having a debate with him. Of course, we all know that the beta blocker are one of the cornerstone that we all use in all our practice, especially when you are a cardiologist. So when you are dealing with hypertension, there still needs for beta blocker. I will start with one of the latest slides presented by Professor Costa, which is the latest European Society of Hypertension guidelines. And as we said, as presented before, that among all hypertensives, there's still beta blocker, as you can see here, is one of the main players that is a class 1 indication with level of evidence B to be used with evidence that it has beneficial effects in blood pressure reduction, cardiovascular prevention, and protection against cardiovascular disease. So it's still existing, the beta blocker, and it's a class 1 with level of evidence B. Especially as presented before, if you are dealing with a hypertensive patient with coronary artery disease, as we can see that in initial therapy, it's a combination that must include the beta blocker, either ACE or ARB plus a beta blocker, CCB plus a beta blocker, or a beta blocker and diuretic. Why, especially in coronary artery disease, hypertensive patient, beta blockers are needed? When we look for all the spectrum of the coronary artery disease, either STEMI, non-STEMI, or the chronic coronary syndrome, we can see that beta blocker are existing for the last guidelines for ST elevation myocardial infarction in 2017, that we can see clearly that it's a class 1 indication if we are dealing a post-myocardial infarction hypertensive patient, especially with a depressed ejection fraction, and it's a class 2 indication, routine oral administration of beta blocker for patients without LV systolic dysfunction. The same for the non-ST elevation acute coronary syndrome published last 2017. Again, as we can see that the beta blocker are still existing. If the patient is already on beta blocker, we should continue the beta blocker unless he's in acute heart failure. This is a class 1 indication, and the oral administration of beta blocker is indicated in all hypertensive patient or patient having LV dysfunction without the presence of a contraindication for the use of the beta blocker. The same in patients with chronic coronary syndrome. Recent guidelines published last year in the last European Society of Cardiology meeting, 2019. And again, beta blocker are existing strongly. And as we can see that the beta blocker are a first-line treatment with to start for control of the heart rate and improvement of symptoms in patients with chronic coronary syndrome. The same when we look for the patient, hypertensive patient with heart failure and reduced ejection fraction, the initial therapy in this patient with hypertension and heart failure are a combination of ACE and ARB plus a beta blocker, plus or minus a diuretic for improvement of the symptoms. And as presented also by Professor Costa, this is based according to the last European heart failure guidelines published in 2016. And as we can see that the ACE inhibitor and beta blocker are the first players and the class 1 indication with level of evidence B in management in this high-risk subcategory hypertensive patient with reduced ejection fraction. And this is a class 1 indication. The third class, also the patient with hypertension and atrial fibrillation, and as we all know that the incidence of atrial fibrillation is almost about 40% in hypertensive patient. And as we can see again in the latest European Society of Guidelines, that the beta blocker with a combination of ACE or ARBs and a beta blocker plus CCB are the initial therapy to be beneficial and to be used in this hypertensive patient with atrial fibrillation. Even patients with CKD, beta blocker are still existing and they are safe to be used in this subcategory if there is compelling indication as heart failure, angina, post-MI, atrial fibrillation, and young women. So according to the last European Society of Cardiology and European Society of Hypertension guidelines, that the beta blocker are still existing in young uncomplicated hypertensive patients without any, with sympathetic overdrive, hypertension with coronary artery disease, hypertension with heart failure, hypertension with atrial fibrillation. The only compelling contraindication that we should be cautious is the presence of acute asthmatic bronchitis, any high-grade AV or sinoatrial block, and severe bradycardia with heart rate less than 60 beats. This is the main compelling contraindication. The other possible contraindication is the metabolic syndrome, glucose intolerance, as also presented by Professor Costa. They are not as seen as with the new generation as nebivolol and carvedilol, as we've seen previously with the old generation of beta blockers as the atenolol. The same as the European Society of Hypertension and the European Society of Cardiology guidelines, the latest Canadian guidelines for hypertension and recently revised in 2020, as we can see that in the first line treatment of adults with systolic hypertension, we can use any of these classes. The only concern for beta blocker, as we can see, are the patient above the age of 60. But if you only are dealing with any hypertensive patient below the level of 60, you are free to start with anyone. So beta blocker are still existing as a first-line treatment and can be used as any classes of antihypertensive with good tolerability and good evidence of cardiovascular protection and improvement of control of this patient, especially as we can see if you are dealing with a hypertensive with coronary artery disease, beta blocker are the main players. Patients with recent myocardial infarction, beta blocker are existing. Patient, of course, with heart failure, they are still existing. So in summary, beta blocker, they can be used as first-line treatment according to the latest European and Canadian guidelines. Other guidelines as the American Cardiology guidelines and the NICE guidelines for England and GNC8 recommend the use of beta blocker when there is compelling indication for their use or in a combination with many other hypertensive. And we all know that now it's really, we can achieve a good control of hypertension and we reach target with a single combination. So usually we are dealing with a combination therapy. Patient with coronary artery disease, whether post-MI, non-STEMI, chronic coronary syndrome, patient with heart failure, reduced ejection fraction, patient with atrial fibrillation, young women, and patient with sympathetic overactivity are the main patients that we are going to benefit from the beta blockers, which, in my opinion, are still existing as a first-line treatment in many of our patients. And thank you so much.
Thank you, Professor Sharif. Line therapy. There is questions to Professor Costa. In the 2005, meta-analysis was done and found that the beta blockers increase the risk of stroke by 17%, and they said goodbye to the beta blocker. So one of the audience asked, does atenolol cause cerebral hemorrhage?
No. What we know that what is a consistent finding in all meta-analysis that beta blockers are less protective for stroke compared to other drugs, and no that beta blockers increase the risk for stroke. This is the consistent finding, and there is no difference between ischemic or hemorrhagic stroke. They protect less than the other antihypertensive medication. Actually, the majority of stroke are of ischemic origin in hypertensive patients. About 80% are of ischemic, different types of stroke, and only 10 to 15% is related to hemorrhagic. Of course, the first, we know very well the linear relationships between blood pressure and the risk for stroke. The less the blood pressure, the less the risk for stroke. And although we believe that all the 5 classes of antihypertensive drugs are equally effective in reducing the high blood pressure, we know that CCBs maybe are more effective in reducing the high blood pressure in let's say in comparing doses, in equivalent doses, and this is the reason that the CCBs are the most effective drugs also for reducing the blood pressure variability. And we know that large blood pressure variability is associated with a higher risk of stroke.
Another question, in 2008, there was a meta-analysis in hypertensive elderly above the age of 60, and they concluded that beta blockers are inferior as a first-line therapy in elderly without angina or heart failure. And there is a question from the audience, can we use ACE inhibitors as a first-line therapy in elderly with LVH?
Yeah, we know the, let's say, the classical recommendation that for younger patients we can prescribe beta blocker or ACE inhibitors, and for elderly people we prescribe diuretics or CCBs, exactly thanks to this to the very well known background that sympathetic activation is less with the advanced age. But on the other hand, we don't have, sometimes the pathophysiology did not, let's say, translated to the clinical practice. We don't have solid evidence, I repeat, solid evidence that beta blockers are not effective in elderly people. Of course, on the other hand, we have to take into considerations that the elderly people have lower heart rate, and this is also a limitation. That's something that we have to take into consideration. Generally speaking, beta blockers are more effective, are more appropriate, I would say. I would not say effective. I would say more appropriated in younger, young patients, not so much for elderly, but we cannot exclude advanced age from prescribing beta blockers.
We welcome Professor Mohammed Lotfi to share with us our discussion. What's your comment?
There is another question from the audience about the effect of beta blockers, especially the new one, on central blood pressure. So the question is for Professor Costa. The effect of beta blockers, especially the new one, on the central blood pressure. What's your opinion, Jason?
Yeah, we know the classical study, the CAFE study, with this unfavorable effect of atenolol on central systolic blood pressure. But of course, as I mentioned in my presentation, and also Sharif highlighted this, beta blocker as not an homogeneous category, and the new agents, carvedilol and danepipulol, with vasodilated properties, have a different effect on the aortic aortic stiffness and the velocity of return waves. So I think that nebivolol and carvedilol did not affect unfavorably the central aortic systolic pressure, and maybe this is one of the reasons for the favorable effect of these drugs in heart failure patients, not only in hypertensive patients. And taking also one more comment, we don't have an ideal method to measure the central aortic blood pressure. This method, the current method, is based on the office blood pressure measurement. That means that they share the same limitations associated with the measurement of the office blood pressure in the brachial. But by the only accurate way is invasive method by a catheter, but it is not practical.
Another question by the audience also is about the use of beta blocker in controlled asthmatic patients and in peripheral arterial disease. Which beta blocker is approved for controlled asthmatic patients and in peripheral arterial disease?
Would you like Sharif to answer? Or
I think it's the same question as we said, that the new beta blockers as nebivolol and carvedilol, the effect of bronchospasm and the arterial vasospasm is not existing, as in the other hand, vasodilator effects, so they can be used safely in patients with arterial disease, peripheral arterial disease, or in asthmatic patient. Unless this patient is in acute asthmatic bronchitis, you don't have to start the beta blocker at this time. But otherwise, patient with a COPD, chronic obstructive lung disease, it's not a contraindication to use the new classes of nebivolol in these classes of patients.
Yeah, this is very important what Sharif just said. No contraindication for patients with OND to prescribe beta blocker if the patient is stable. The same is true also for patients with peripheral vascular disease. No contraindication for beta blocker administration.
Another question, my question to Professor Costa, in coronary artery disease, in stable coronary artery disease patients, beta blockers have no prognostic implications. The guidelines recommended to control the heart rate and angina. What's your comment about this?
Yes, this is true, but for patients with a history of previous MI, particularly in the early period after MI, for the first 2 years, this is not so well defined, let's say a period of 2 years, I think beta blocker has shown also their protective effect in terms of cardiovascular event. For patients without a history of heart failure, without a history of a previous MI, beta blocker are good drugs, are good choice for improving the symptoms, for controlling the heart rate, for controlling the high blood pressure, but not for improving the expectancy of life.
Professor Lotfi, you have a question or?
I think that in this session we demonstrated elegantly the use of beta blocker in the management of hypertension. Professor Costa and Professor Sharif Wagdi showed when to use and when not to use. When to use, it's very clear by the talk of Professor Sharif Wagdi, and he said that we have to use beta blocker in hypertension with heart failure, hypertension with ischemic heart disease, and in young patients, and if there is sympathetic overdrive in young patients. On the contrary, if we want more protection, and we have to use the other classes of antihypertensive medication in order to reduce the cardiovascular morbidity and cardiovascular mortality. I think this is the sum of this session.
We have to end the session. Thank you, Professor Costa. Thank you, Professor Sharif. Thank you, Professor Lotfi. And we are waiting for you in the next Friday to discuss the hypertension and the comorbidity, 2 sessions, and followed by another debate. Thank you for all. Thank you very much.
Thank you so much. Have a nice weekend. Bye-bye.
Thank you. Thank you.